Okay, so today we will have a very interactive class. A 4-year-old boy is evaluated for profound hypoglycemia and seizures. Examination is remarkable for non-tender hepatomegaly. Okay, hepatomegaly is there and very profound hypoglycemia. He has a history of multiple hospitalizations for seizures and hypoglycemia. Okay, since he was 6 months old. His parents have noticed that he was never tolerated even short periods of fasting with. So intolerably profound hypoglycemia. You have to understand, intolerably profound hypoglycemia. In his previous hospital stage, low blood glucose level were consistently observed within a few hours after each feeding. He has also repeatedly had lactic acidosis, hyperlipidemia, and hyperuricemia. You can see extra additional symptoms. Hypoglycemia and hepatomegaly, two are there. And these are hypoglycemia and hepatomegaly is actually common presentation in glycogen storage disease. 2H, hepatomegaly and hypoglycemia. Here you can see lactic acidosis, hyperlipidemia, and hyperuricemia. They are peculiar to this disorder. 3. Lactic acidosis, hyperlipidemia, and hyperuricemia. A liver biopsy indicates excessively accumulation of glycogen and fat. So what is the most likely diagnosis? So yes, von Gierke disease. So von Gierke disease is diagnosis. Now, why is hepatomegaly seen? The simple logic is because it is glycogen storage disorder, and that is why accumulation of glycogen. Wherever you see hepatomegaly, the cause is accumulation of glycogen. Simple as it is, because there is disorders in breakdown of glycogen. Now, which is the explanation for patients severe fasting hypoglycemia? First explanation for hypoglycemia, and then lactic acidosis. So what is the explanation? Can you see what is the cause of this hypoglycemia? Fasting hypoglycemia. I'll ask you a question. So during fasting condition, which pathway maintains your blood glucose level? Which all pathway maintains your blood glucose level during fasting condition? Because during fasting condition, you are not taking any glucose. That is why it is fasting. And in such condition also, blood glucose is being maintained. Why? Because there are some pathway that are dedicated to maintain this. Okay, glycogenolysis, that is a good answer. One is glycogenolysis. Other pathway that maintains blood glucose level during fasting condition, one is glycogenolysis, second, two pathways are there. One is glycogenolysis, second is gluconeogenesis. Two pathways are there which maintains blood glucose level. Great. Everybody is actually answering. Good. So glycogenolysis and gluconeogenesis, two pathways are there which maintain fasting glucose level. If until your liver has glycogen storage, the liver will try to maintain, your body will try to maintain glucose through glycogenolysis. And normally this happens. And after a certain period, your glycogen is consumed. After 18 hours, glycogen is consumed. Then your body has to depend on gluconeogenesis. Okay. So first 18 hours, you can simply say 1 day. Your body, your liver actually contribute, hypoglycemia actually is countered. Glucose level is maintained by glycogenolysis. Then gluconeogenesis. So that is why you can say here, why when one pathway is active, either of the two pathways if active, if glycogenolysis is active and this glycogenolysis is active, but this gluconeogenesis is inactive, then also will be hypoglycemia. But you know, glycogenolysis can cope up for few hours, and that is how for few hours patient can tolerate. But if glycogenolysis and gluconeogenesis both are absent, then there will be severe hypoglycemia. If one is present, so one can compensate for other. But if both are absent, then you can expect severe hypoglycemia. And you know, both are absent in von Gierke disease. That is why you can see intolerably profound hypoglycemia. And hypoglycemia is actually presentation of your fuel disorder. I will tell it a fuel disorder. Why do I call it? There is, you will not find any places fuel disorder. It is just colloquial language so that you will understand. Fuel means your fuel is carbohydrate and lipid. Even you have seen MCAT deficiency also, there is hypoglycemia, non-ketotic hypoglycemia. Okay, non-ketotic hypoglycemia. Why? Because there is no gluconeogenesis. Gluconeogenesis requires energy from fatty acid oxidation. So fuel burning, whenever there is problem in fuel system, there will be hypoglycemia. There is a chance of hypoglycemia. No, I wanted to, why I told you this MCAT deficiency, so that you can correlate with this hypoglycemia. Whenever you see in question hypoglycemia presentation, you have to have a differential diagnosis of that also, that MCAT deficiency also. So you can see profound, intolerably profound hypoglycemia is because of lack of both pathways, gluconeogenesis and glycogenolysis. And why is there lactic acidosis? So I have already told you causes of lactic acidosis in MD1. Can anybody tell me what is the cause of lactic acidosis? So glycolysis is increased, and that is why what will happen when glycolysis pathway is increased. If you see after glycolysis, what happens? Krebs cycle. So Krebs cycle, the speed of Krebs cycle will not match with the speed of glycolysis. So there will be apparent blockade like thing. So if fuel is supplied more for Krebs cycle, but Krebs cycle cannot burn those all fuel. So there will be practical blockade, you can imagine. The fuel flow will be very fast. You can see some river is flowing very fast, but at some point there is the speed of that river, the channel cannot tolerate that speed. So what will happen? The flow will divert to some other place. So flow will divert to lactic acid synthesis. That is a very important. So yes, anaerobic glycolysis is there. There is anaerobic glycolysis. So whenever lactic acid is forming, so you can see oxygen is not being consumed. Directly, indirectly, it is anaerobic glycolysis. So what do we call anaerobic glycolysis? Anaerobic glycolysis is just a terminology for our convenience. Okay? Whenever oxygen, how glycolysis behave in absence of oxygen. The same way, the glycolysis behave when the speed of glycolysis is increased. If you can imagine, I told you cancer cell, their glycolytic speed is very high, and that is why there is production of lactic acid. Okay, so when glycolytic speed is very high, there will be production of high lactic acid. This is a very important. And then cause of hyperuric acidemia, I have already told you. If you can remember, can anybody tell me? Here, in von Gierke, what is the cause of hyperuricemia? I mentioned you two disorders. One disorder is Lesch-Nyhan syndrome. I told you to memorize two disorders where you will find hyperuric acidemia. Lactic acid competes with uric acid excretion. That is a good answer. Actually, hyperuric acidemia actually causes lactic acid. Yes, PRPP. PB is correct. PRPP. Okay. PRPP. I told you to memorize the terminology. This 4-letter word, PRPP, phosphoribosyl pyrophosphate. It is a feed-forward stimulator of enzyme amidotransferase. Which amidotransferase? PRPP amidotransferase. Just remember amidotransferase. This is a feed-forward stimulator of amidotransferase. High PRPP is the reason for both Lesch-Nyhan syndrome and von Gierke disease association with hyperlipidemia, hyperuric acidemia. So PRPP, and yes, you are not incorrect, lactic acid also contributes. So both are the reason. So did you all understand the explanation here? And see, hypoglycemia and hepatomegaly, and this fasting intolerance, intolerably profound hypoglycemia is caused fasting intolerance. There are two types of intolerance, I'll tell you. One is fasting. I'm telling you this term, these are very like lofty type of term, and you will find very enjoying term. Fasting intolerance, and there is second term is exercise intolerance. Two types of intolerance are associated with fuel disorder. I will tell you fuel disorder. Fuel disorder means disorders of burning of glucose, disorders of burning of this glycogen degradation, disorders of this lipid means fatty acid oxidation. These are associated with this intolerance, fasting intolerance and exercise intolerance. Remember two terms there, fasting intolerance. So these 3-4 features are very common features you will see in all fuel disorders, not only in glycogen storage. So hepatomegaly, okay, not all, it is there, these are general presentation. You can see hepatomegaly here, hypoglycemia, very severe hypoglycemia, and then fasting intolerance. And these three are very peculiar to von Gierke disease. You will see lactic acidosis, hyperlipidemia, hyperuric acidemia. So you have already explained the causes. I don't need to go into explanation. So you know the diagnosis already you have done. Now cause of hepatomegaly is accumulation of glycogen because of inhibition of glycogenolysis. And then cause of hypolipidemia, hypoglycemia is inhibition of gluconeogenesis and glycogenolysis both. Okay. So you can write inhibition of gluconeogenesis and glycogenolysis. So why gluconeogenesis and what is it? No problem. So gluconeogenesis and glycogenolysis both are inhibited. So why I have written gluconeogenesis? If glycogenolysis is absent and gluconeogenesis is present, there will not be that profound hypoglycemia. This gluconeogenesis take over that hypoglycemia. But if both are absent, there will be profound hypoglycemia. Both are absent. Why hyperlipidemia? Increased glycolysis. That is why high hyperlipidemia. So this is the cause of high hyperlipidemia. So you know glycolysis from what? Pyruvate. Acetyl coenzyme is formed, and from acetyl coenzyme, you know, lipid is formed. So increased glycolysis, that is how means increased lipid. So you can directly remember this way. Why hyperlactic acidemia? Again, increased glycolysis will produce lactic acid. That is why. And this cause of hyperuricemia, I have mentioned this cause, okay, high PRPPs, because I want to memorize for biochemistry. This is the most important. Second cause, yes, you are rightly said. I'm happy for that. This lactic acidemia, high lactic acid, because uric acid is alkaline soluble. I've told you it is soluble in if you alkylating agent if you put in your body, so it will be soluble and it will go out of the body. But acidemia, uric acid does not solubilize, it will be actually crystallized. So that is why it will not be excreted through the kidney. So high lactic acid is also contributing factor for secondary contributing factor for hyperuricemia. The first is high PRPP. So will you memorize this for von Gierke disease? I want reply.
Yes, sir.
Yes. So memorize this. Yes. And how do you remember LUL? Hyper LUL. So what is HH LUL? So L for lactic acidosis, and then U for uricemia, and L for lipidemia. Lactic acidosis, uricemia, LUL is very peculiar to this, and then hyper to HH-LUL. So you can see hepatomegaly and hypoglycemia, 2HH and LUL. So HH is common presentation. You can see general presentation of this glycogen storage disorder. And not only glycogen storage, I want you to correlate this glycogen storage disorder also with other fuel disorder. So go back and you can see, review that MCAT deficiency, okay? So that you can conceptualize, you can put everything together, all the pathway together, you can understand that. Now, so you can see massive hepatomegaly. This is massive hepatomegaly in 5-year-old kid. Okay, this is massive, and this is autosomal recessive disorder. So you can find both in male and female equally. This is boy. Okay, now metabolic alteration in bone glycogen. See, I'll tell you this glycogen. So imagine, so this pathway, if you consider the same way as pathway is written, so you will not have that extra edge. I will tell you one thing. I want you to imagine it inside hepat. Though this is liver, liver has hepatocyte, one hepatocyte here. I have to draw it large. So see what happens in hepatocyte. Each hepatocyte, many hepatocytes will be there, and each hepatocyte, what is happening? So this is glycogen. This is glycogen. This is glycogen in protein. Glycogen. So what happens is this glycogen will break down. The enzyme that degrades this glycogen is phosphorylase. You know it very well. Phosphorylase. And you know phosphorylase breaks this glycogen into glucose 1-phosphate. And this glucose 1-phosphate is converted into glucose 6-phosphate by an enzyme called mutase. Mutase. Which mutase? You can easily remember. At least remember this last name, the function, phosphorylase and mutase. That is why, because you will not, if you try to remember everything, you will not be able to remember anything. So try to remember the main thing. Now this glucose 6-phosphate has to be converted into glucose by an enzyme. What? Phosphatase. This glucose 6-phosphatase. G6-phosphatase. And this enzyme actually, normally this enzyme is absent where? This enzyme is normally absent in liver. Normally absent in liver. So that is why liver will not be affected because of this deficiency. But once this enzyme is deficient in liver, what will happen? So there will be obstruction. When there is obstruction, you know, this will be high. And this glucose 6-phosphate, you know, it is not permeable. That is why it does not have ability to go out of the cell. So glycogen degradation is downhill process. That is why you can imagine this way easily. Now what will happen? Because of this accumulation, you know, this product is inhibitor. So this product will inhibit this. This product will inhibit this. Because of inhibition, when there's, just imagine one thing. So this granules, glucose 6-phosphate granules is increased inside cell. Glucose 6-phosphate granules, very many glucose 6-phosphate is very high inside cell. Very high glucose 6-phosphate. And this glucose 6-phosphate is blocking the flow of this glycogen degradation, glycogenolysis. So you can imagine that way. These are inhibiting this. Because of this, what will happen? Many glucose 6-phosphates are there. So one is blocked. Once this is blocked, so what will happen? This, I have told you in glycolysis, if you can remember this glucose, when it converts into glucose 6-phosphate, this is trapping reaction. Through this 3 pathway goes. One is glycolysis, one is glycogen synthesis, glycolysis. Because glycolysis is more regulated by allosteric regulation than by hormones. So glycolysis will be high. Hormone will also regulate glycolysis, but more under allosteric regulation. If glucose 6-phosphate is very high, so glycolysis will happen. Now glycolysis will happen, then pentose phosphate pathway will happen. So remember this three parts. And glycolysis, fate of glycolysis, what is the fate of glycolysis? You can see fate of glycolysis is acetyl coenzyme A and then fatty acid here. And here fate of glycolysis is, if glycolysis is very high, there will be lactic acid. So glycolysis is caused for lactic acid and lipid. Glycolysis is caused for lactic acid and lipid. And this pentose phosphate will contribute to PRPP. And this, PRPP is uric acid. So you can imagine this three pathway. You can see three pathway connects. Glycolysis, high glycolysis, and pentose phosphate pathway is the problem for everything. And glycogen storage. So you can easily understand. Imagine in your brain that okay, inside liver of such patient, many granules of glucose 6-phosphate will be accumulated. That will actually push the reaction, actually obstruct the reaction of glycogen degradation from happening, and then push that glucose 6-phosphate is a flux generating. This I've told you, this is a first flux generating reaction for this. So it will generate a flux for glycolysis and this pentose phosphate pathway, and these two pathway will happen in very high speed, and that is why this lipid, lactic acid, LL and LUL. So remember this very important concept. So now can you understand this glycogen degradation? Because of this, it will accumulate very high, and because it cannot cross this enzyme is absent, cannot cross the membrane. So that is why glycolysis will be very high. And see, once glycolysis happens, why gluconeogenesis does not happen? Because glycolysis and gluconeogenesis, these are mutually exclusive process. Remember, you can write somewhere. I will tell you in gluconeogenesis, this glycolysis and gluconeogenesis, these are very mutually exclusive process. If glycolysis happens, gluconeogenesis cannot happen. So you understood why gluconeogenesis is not there?
Yes, sir.
Because of glycolysis, high speed. Because glycolysis and gluconeogenesis cannot coexist in liver. We are talking about liver because this is hepatic glycogen storage. This everything happens in liver. This is completely associated with liver. Other organ is not involved here. Because of this hypoglycemia, brain is involved. Okay, other organ, not directly. So gluconeogenesis, that is why gluconeogenesis, glycogen, both are present. Okay, so you can see this picture easily. So PRPP with uric acid, hypoglycemia. Why? When this is very fast, so there will be production of hyperlipidemia. You can understand from this picture. So once you have understood this bone Gierke disease, we can compare this with others and you can understand all. Let's see this. So bone Gierke disease, you can see, as I have told you, HH hyperlung. You can understand HH, hepatomegaly, hypoglycemia, LUL. So lactic acid, uric acid, and what else? Lipid, lactic acid, and uric. So remember this mnemonics, and you already know the explanation for this. Either high glycolysis or pentose phosphate. These are the explanation for everything. High speed of glycolysis and pentose phosphate, high speed of pentose phosphate. These are the explanation of everything. Okay, and that too because of accumulation of glucose 6-phosphate. And then, and for why does gluconeogenesis does not happen? Because two pathways are glycolysis is inhibitor of gluconeogenesis. If glycolysis happens in high speed, gluconeogenesis is obstructed. So treatment, you can see the treatment. Because glucose, actually, this patient is having glycogen degradation disorder. So frequent meal has to be given. You don't give a bulk amount of carbohydrate at once, because when you give it, that carbohydrate will, if there is very high amount of carbohydrate, it will try to accumulate again into the liver, glycogen. That is why glycogen will build up. Okay, because the patient will take the glucose and the glycogen degradation is not happening. And I told you, actually, three pathway. I told you this three pathway. Glucose 6-phosphate will accumulate, and because of this three pathway, glycogen. So if you give glucose from outside, so what will happen? Normally, if you don't give glucose, this glycogen will not be formed that much. But glycolysis and then pentose phosphate path. So if you give glucose from outside, what will happen? That is why this hepatomegaly. So glycogen will increase because of this accumulation of this, and there is no going outside, and that is why it will accumulate and it will stimulate this pathway also. But if you limit, so this pathway will not happen. If you limit slowly, glycogen will divert this, and this pathway will not happen. Anyway, so that is why this is the cause for hepatomegaly. Hepatomegaly. This is the cause for this is the cause for uric acid, and this lipid, lactic acid, and low glucose. This is the cause for this thing. So you can easily memorize from this. So that is why you need to limit what? You need to limit. You need to limit a bulk carbohydrate intake. So frequent but small amount of carbohydrate. Avoidance of fructose. Fructose directly converts into fat. There's no regulatory step. That is why try to avoid other thing. Glucose, fructose, and galactose also. So because galactose conversion will also be difficult, avoid those material. And impaired gluconeogenesis and glycogenolysis. I told you gluconeogenesis, that is the cause for hypoglycemia. Both are impaired. And you can see severe fasting hypoglycemia. I have already explained. High glycogen in liver. Okay, glycogen is very high in liver. That is why this lactic acid, hypertriglyceridemia, uric acid. So I have already explained this all. So you can go to this is the picture from first aid. I told you directly I will talk about this, so that